In the second video, we will talk more specifically about pediatric EKGs. We will talk about indications for EKGs, lead placement for pediatric patients, and pediatric norms and common findings for rate, rhythm, axis, and intervals. Indications for EKGs are similar in children and in adults. Some indications for EKGs include suspected dysrhythmias, syncope, electrolyte abnormalities, ingestions, chest pain, suspected congenital heart disease, and screening in patients with a family history of sudden death or other life-threatening event. Pediatric EKGs are 15-lead EKGs, as opposed to the 12-lead EKGs done in adults. The extra leads give us more information about the right side of the heart, which is a more common area of pathology in children. Limb lead placement in children is similar as in adults, with right arm, right foot or leg, and left foot or leg leads. For the precordial leads, V1 through V6 are also the same as in adults. V1 and V2 are on either side of the sternum in the fourth intercostal space. V4 is in the mid-clavicular line in the fifth intercostal space. V3 is between V2 and V4. V6 is in the fifth intercostal space in the mid-axillary line. V5 is equidistant between V4 and V6, and V7 is equidistant from V6 as V5. Leads V3R and V4R are mirror images of V3 and V4 on the right side of the chest. This table shows the normal pediatric ranges by age for various aspects of the EKG and is a good reference when interpreting pediatric EKGs. We will use this table as we go through the various components of the pediatric EKG. First, when calculating the heart rate, it is important to be aware of the patient's age, as normal heart rates vary by age. In general, heart rates decrease over infancy and childhood, reaching normal adult values by adolescence. However, it is important to note that sinus bradycardia can be normal in athletic adolescents. Narrow complex tachycardia is a common abnormal finding on pediatric EKGs. This is a flowchart for evaluating narrow complex tachycardia. When tachycardia has narrow QRS complexes, that indicates that the tachycardia originates above the bundle of His. It can be sinus tachycardia, with P waves originating from the sinus node, or supraventricular tachycardia. Supraventricular tachycardia can be caused by atrial ectopic tachycardia, in which you will see abnormal P waves, or a reentrant tachycardia with no P waves, either a reentrant tachycardia with accessory pathway or AV nodal reentrant tachycardia. This EKG shows an example of supraventricular tachycardia. As mentioned, the first thing to look for is P waves. In this example EKG, you can see that there are no P waves. Thus, this is an example of supraventricular tachycardia with a reentrant pathway. When looking at the rhythm on a pediatric EKG, one important thing to note is that sinus arrhythmia is very common. Sinus arrhythmia is an arrhythmia in which the rate varies with respiration. When the child is inhaling, the heart rate will increase, and when the child is exhaling, the heart rate will decrease. This arrhythmia will disappear with exercise, which will help you differentiate sinus arrhythmia from other arrhythmias. Another common finding on pediatric EKGs that will lead to an irregular rhythm is premature atrial contractions. Premature atrial contractions are caused by early depolarization of the myocardium in the atrium. The P wave morphology will be different from the sinus beats, and the PR interval may be longer. However, the QRS will still be narrow. Premature atrial contractions are followed by a non-compensatory pause. They are most likely benign in asymptomatic children. Premature ventricular contractions are also common findings on pediatric EKGs. They are caused by early depolarization of the myocardium in the ventricles. Because the contractions originate below the bundle of His, the QRSs are wide. They are also followed by a compensatory pause. PVCs can occur in patterns, such as bigeminy, trigeminy, couplets, or triplets. The top image shows a single isolated PVC. The second image shows the pattern of bigeminy with alternating PVCs and sinus beats. The third image shows both a couplet and a triplet. A couplet is when two PVCs occur together, and a triplet is when three PVCs occur together. The differential diagnosis of PVCs is broad. They can be idiopathic, but they can also be caused by abnormalities such as cardiomyopathies, heart failure, myocarditis, endocrinopathies, electrolyte derangements, and drug effects. The next aspect of EKGs that you will look at is the axis. The normal axis, like the heart rate, varies by age. In utero, the right ventricle is hypertrophied, so when infants are first born, the axis is generally rightward. The axis shifts to the adult norm over about the first year of life. For example, the mean axis in neonates is about 100 degrees. By the time children are 3 months of age, the mean axis has shifted to about 65 degrees. You can refer to the table earlier in the slideshow for the mean axis and normal range of axis by age. Finally, we will look at the intervals. Conduction intervals, such as the PR and QRS intervals, are shorter in children due to the smaller heart size. About 10% of normal children will have episodes of first-degree heart block, more commonly during sleep, due to increased vagal tone. Also, about 10% of normal children will have episodes of Mobitz type 1 heart block. The QTc in children is generally similar to that in adults. However, in infants younger than 6 months of age, the upper range of normal is higher, at about 0.49 seconds. Looking specifically at PR intervals, prolonged PR intervals can be caused by myocarditis, certain kinds of congenital heart disease, hyperkalemia, or first-degree AV block. Short PR intervals can be caused by pre-excitation or certain kinds of glycogen storage disease. Variable PR intervals can be caused by wandering atrial pacemaker or multifocal atrial tachycardia, or Mobitz type 1 heart block. This slide shows various examples of abnormal PR intervals. In the first EKG strip, you can see a prolonged PR interval consistent with first-degree AV block. In the second EKG strip, you can see a shortened PR interval with delta waves. In the third EKG strip, you can see a variable PR interval and a missing QRS, consistent with Mobitz type 1 heart block. Short PR intervals with delta waves are caused by Wolff-Parkinson-White syndrome. An EKG with delta waves is seen on this slide. Wolff-Parkinson-White syndrome can predispose to supraventricular tachycardia, atrial flutter, or atrial fibrillation. Prolonged QRS intervals can be caused by bundle branch blocks, pre-excitation conditions, intraventricular block, or ventricular arrhythmias. On this slide, you can see a wide QRS due to ventricular tachycardia. You may also see abnormalities in the corrected QT interval. A prolonged QTc can be seen in hypocalcemia, myocarditis, long QT syndromes, drug effects, or head injury. A short QTc is more rare and is defined as a QTc less than 320 milliseconds. It can be seen in hypercalcemia, with digitalis use, or in congenital short QT syndromes. This slide shows an example of a prolonged QT and a short QT. In the first example on the left, you can see a prolonged QT interval. The QT appears to be about half the RR interval, and when calculated, the QTc is prolonged at 569. On the right, you can see an example of a short QT interval, potentially from a patient with a short QT syndrome. Let's end this presentation with another practice case. This is the EKG of a 15-year-old female with no significant medical history who presented for screening due to a family history of sudden death. Again, look at the calibration, rate, rhythm, axis, and intervals.